All right, let's jump right in, shall we? Today, we are running a rapid-fire, high-yield masterclass, and it's designed specifically to lock in those absolutely critical points for your high-stakes medical exams. We're taking the super dense, honestly kind of overwhelming world of infection control and transmission bundles and distilling the whole shebang right down to exactly what you need to know to succeed in this explainer.
So, here's the game plan to guarantee you those points on test day. Number 1, high-yield HIA basics. Number 2, a transmission precautions masterclass. 3, device-associated infection bundles. And 4, the ultimate exam traps. Let's do this. Section 1, high-yield HAI basics, setting the baseline.
Okay, let's lay down the absolute foundation before we get to the complex stuff. A healthcare-associated infection, or HAI, is strictly defined as an infection occurring at least 48 to 72 hours after hospital admission. Now, you might be wondering, why is that specific window so crucial? Well, examiners love, and I mean literally love, to use that 48 to 72 hour mark as a classic distractor in clinical vignettes. Right? If a patient spikes a fever 12 hours after admission, that's community acquired. But if it happens on day 4, boom, you are dealing with an HAI. Lock that time frame into your memory right now.
And just to really underscore the sheer scale of this issue, take a look at this. 3%. HAIs affect at least 3% of hospitalized patients at any given time. That is a massive clinical burden. Oh, and if you're wondering what the most frequent hospital-acquired infection in the US actually is, it's C. diff. Moving on to Section 2, Transmission Precautions Masterclass, the Core Matrix. All right, it's time to build your mental scaffolding. You need to know these 3 major buckets totally cold. Let's walk through how this builds up. First up, contact precautions. For this, you just need a gown and gloves. Think pathogens like C. diff, MRSA, and VRE. Next, we step it up to droplet precautions. Here, we build on our PPE by adding eye protection and a mask. This is going to cover your heavy respiratory droplets, stuff like influenza, RSV, and pertussis. Finally, the big one, airborne precautions. This demands a fit-tested N95 respirator. Why? Because we're dealing with tiny aerosols that literally hang in the air, so it requires a completely different level of protection.
So, the crucial point here is knowing exactly which pathogens require that strict airborne isolation. I like to call them the airborne 3. If you see tuberculosis, measles, or varicella on an exam, your brain should immediately flash to airborne precautions. Seriously, examiners will endlessly test your ability to separate these 3 from your standard droplet viruses like the flu. Don't fall for it.
And when you do spot an airborne pathogen, this is the magic number you need to know: 12. Airborne precautions absolutely mandate placing the patient in a negative pressure isolation room that performs greater than or equal to 12 air changes per hour. Plus, it needs HEPA filtration. Basically, if you don't have 12 air changes, you simply don't have a compliant airborne isolation room. Simple as that. Section 3, device-associated infection bundles, visualizing the procedure. Okay, let's talk central lines and CL LabSci, central line-associated bloodstream infections. Did you know having a central line triples a patient's in-hospital mortality risk? Triples it. It's wild. So obviously, prevention is absolutely paramount. The protocol kicks off with the aseptic insertion bundle. That means full barrier precautions, a sterile drape, and chlorhexidine skin prep. But the ongoing prevention? That is highly testable. We're talking daily 2% chlorhexidine gluconate full-body baths. This isn't just a nice-to-have idea. It's the critical ICU standard of care for central line patients. Next up is the urinary catheter, and man, this introduces a massive exam trap. With prolonged catheterization, bacteriuria is completely inevitable. It's gonna happen. The rule of thumb is that asymptomatic bacteriuria in a catheterized patient usually requires absolutely 0 treatment. Please do not throw antibiotics at it. The only exception, well, if the patient is pregnant or about to undergo a urologic procedure. Otherwise, the only true prevention for a true CAUTI is a daily review to rip that catheter out as soon as humanly possible. Then we have the VAPE, or ventilator-associated pneumonia, prevention bundle. Up to 10% of ventilated patients will get this, and yeah, it can be fatal. The absolute critical steps include elevating the head of the bed to 30 to 45 degrees, strict oral decontamination, subglottic secretion drainage, and crucially, the daily sedation interruption, or SAT. We do this to see if they can be extubated, because honestly, the fastest way out of that 10% risk pool is to just get the tube out while, avoiding unnecessary reintubations, of course. Section 4,
Ultimate exam traps, the exceptions they love to test.
All right, tone shift. Let's get into high alert here. Let's start with the classic active recall prompt. Listen to this vignette. A patient is admitted with severe diarrhea and tests positive for C. difficile. You finish examining them and remove your gloves. What is your next mandatory step? Take a second. Think you got it? And this brilliantly illustrates one of the most frequently tested rules in all of medicine. If you chose alcohol-based hand gel, you just failed the question. Sorry. C. diff creates spores that absolutely survive alcohol-based gels. They'll literally just laugh at your hand sanitizer. The mandatory step here is good old-fashioned soap and water. Why? Mechanical removal. You are physically washing those spores right down the drain. Oh, and by the way, standard room cleaners, they don't work either. That room requires sporicidal bleach. Let's try another board-style prompt. You ready? A resident suffers a needle stick injury from an HIV-positive patient. What is the absolute deadline to start post-exposure prophylaxis? The answer is 72 hours. Lock this high-yield metric in right now. HIV, triple antiretroviral post-exposure prophylaxis, or PEP, has to start within 72 hours of the injury, and it runs for 28 days. Now, as a quick comparison, if this were a hepatitis B exposure, the healthcare worker needs hepatitis B immune globulin way faster. We're talking within 24 hours. But here's the real trap examiners love to set when it comes to needle sticks. They'll give you a patient with hepatitis C, and then they'll generously offer you a whole list of prophylactic drugs in the multiple choice options. The correct answer? Monitor only. Yep, there's absolutely no effective post-exposure prophylaxis for Hep C right now. Unlike Hep B and HIV, which need immediate active intervention, Hep C is entirely a waiting game. You just do serial testing at 6 weeks, 3 months, and 6 months. Now, what's really interesting here is contrasting the airflow direction rules. We already established that a TB patient goes into a negative pressure room, right? That keeps their germs from escaping out into the hallway. But what about an immunocompromised patient with prolonged neutropenia? Well, they need a positive pressure room with HEPA filtration. The trap examiners use here often involves a vignette about hospital construction. Construction dust near a ward is a massive risk for circulating mold spores, like Aspergillus. Positive pressure pushes the air out of the patient's room, keeping those dangerous spores far away from their vulnerable immune system. Let's take a look at a modern exam favorite, Candida auris. This is a highly dangerous, multi-drug-resistant fungus. But what makes it so testable is how it behaves. It is perfectly adapted to survive in the healthcare environment, specifically on shared medical equipment. We're talking blood pressure cuffs, temperature probes, glucometers, the works. It frequently sneaks into the ICU when patients are admitted from long-term care facilities, and it requires extremely strict contact precautions and specialized sporicidal disinfectants. And then there's nosocomial Legionella. Legionella pneumophila loves to colonize the biofilm in pipes and cooling towers. The rule here is incredibly extreme, which, you guessed it, makes it a perfect test question. It literally takes just one single case of hospital-acquired Legionella to trigger a massive, immediate, full-scale investigation of the hospital's entire plumbing system. Just one single case shuts down and tests the whole water grid. Crazy, right?
So, as we wrap up this masterclass explainer, I want to leave you with a bit of a provocative thought based on everything we've just covered. If a highly virulent, new, multi-drug-resistant organism, one fully adapted to survive our absolute best hospital disinfectants, emerged tomorrow, which of our standard infection control bundles would fail first? It really reminds us that infection control isn't just some boring list of rules to memorize for a test. It's a constant, evolving battle between human protocols and microbial adaptation. So keep mastering these bundles, stay incredibly sharp on those exam traps, and I'll catch you in the next explainer.